chemotherapy for those patients with a good result. Some data of more than 60% local control after 2 and 3 years. So I think for this particular patient with this large tumor with undifferentiated histology, I would go for radiochemotherapy and have surgery as a mainstay of treatment after radiochemotherapy.
Very good. Professor Seifert?
That's a pure ENT case as far as I see it.
Right.
So I can just applaud your success and then say, well done, well done.
Okay.
Nothing I can add to this sort of surgery.
Okay. Dr. Rapides?
Well, on the contrary, in this case, where from what I saw, I didn't see an MRI, it was just a CT, it looks resectable to me. So I would go with primary surgery. And then if I have if I don't have clear margins, I will do radiotherapy. What I wanted from the previous, sorry to go back, to hear from the audience is their views on intraoperative radiotherapy. It's something that it has been done to gynecological cancer and lately to cancer of the breast. So, but I haven't seen any studies for intraoperative radiotherapy in anterior cranial-based surgery, which I don't know whether you use it here, Professor Budek, or you.
I can comment on that.
Please.
Intraoperative radiotherapy is a good means in several tumor types, for example, in abdominal sarcomas, for example. But I think the limitation for intraoperative radiotherapy in this particular site of tumor is that you have a very infiltrating tumor, and even with electrons, for example, that you can apply intraoperatively, you will probably not eradicate these small infiltrating tumors. I think it's a more important approach to use, for example, IMRT technology in this, or even more important, and in recent years more and more coming, is proton or heavy ion radiotherapy. For example, we have in Darmstadt nearby an institute which deals with heavy ion radiation, and they have presented and published excellent data on these type of tumors with a combinations of external IMRT radiotherapy plus a heavy ion boost. And I think this is a much worthwhile approach than to apply intraoperative radiotherapy.
No, I was meaning intraoperatively, when you have removed the tumor and you have suspicion that you have left behind microscopical disease, there are some, I think they can be up to 9 MEV radiotherapy machines that can be used during the operation.
That's possible, yes.
Yeah, they have some collimators with, they have a 2 centimeter.
Right.
Oh, come on, Professor Budek, I'm not going to. Yeah, tell us.
I think there is no evidence until now that interop irradiation in such a specific situation really can be of help, and it's also a problem of the target volume with all these edges and small, very small cavities. I don't think that you really can approach it with, for instance, brachytherapy. You only could approach it perhaps with electrons, fast electrons, but then we have also a problem because the situation is going in a depth of 6 centimeters or something like that, where we have already problems with the entrance dose, sufficient entrance dose of electrons. I would also see here more a case for post-op photon irradiation, or in a high-risk situation, radiochemotherapy, post-op radiochemotherapy, or if available, of course, protons or heavy ions, but this is only available in very few institutions.
Professor Boots, any comments on this case?
Well, I would agree what you have said. I would operate on this patient, and the problem is, are the margins free or not? Since the tumor is so close to the adjacent areas, it's often very difficult to point out whether you are free, or the margins are still involved in tumor. So I think in all these cases with a large extension of malignancies in the paranasal sinuses, you should add radiotherapy or chemotherapy. But I would say more tend towards radiotherapy than to chemotherapy. But you also have to be aware that this is an old lady, and the morbidity by chemotherapy might be quite high in her.
I just want to add one comment, because as I am aware, there is a study in North America from the North American Skull-Base Society which directly addresses this question of preoperative radiochemotherapy for these cases and randomized between surgery up front. So hope that this study runs well in your country and that we finally find out whether radiochemotherapy up front is of benefit for these patients.
I'd like to open this up to the audience, and again, particularly the medical oncologists and their feeling about the role of induction or concurrent chemo radiotherapy for sinonasal undifferentiated carcinoma. Comments? Lori, any comments?
I think I would make the same comment that Dr. Bruton has made earlier, that there's really an absence of data at all for induction chemotherapy in this situation, although it has certainly come up on an anecdotal basis here and there, especially when patients refuse upfront surgery, and you can see some surprisingly good results. The other thing that I would add is that there's also a fair absence of data on the addition of chemotherapy to radiation in the adjuvant setting, but that is something that we often consider. And in our experience, the addition of a weekly platinum-based chemotherapy to radiation is fairly well tolerated post-operatively in this patient population. We tend to not see all of the difficulties with mucositis and esophagitis that you see in the typical head and neck cancer patient, and in that regard, it's much easier. Patients usually don't require PEGs, are able to eat throughout their treatment. And you can always pull back on the chemotherapy as well if it's getting to be too difficult for the patients.
Thank you. We have some as yet unpublished data that will be presented this summer at the meeting in San Francisco by Ehab Hanna and colleagues from our medical oncology department, Bonnie Glisson and Merrill Keys. And essentially with sinonasal undifferentiated carcinoma, those who receive induction chemotherapy and don't have a major response are very difficult to salvage with either surgery or chemoradiation. And this is a retrospective experience, but a fairly large one. And but we tend to have good experience with the combination of chemoradiation, and rarely do we do surgery up front for these patients. Dr. Olson.
Yeah, just like to make a comment that I think as we're looking at patients with sinonasal undifferentiated cancer, that we have a big plea to make sure that our pathologists have adequately examined those patients and done appropriate immunostainings. There's a lot of tumors that are classified in the past as sinonasal undifferentiated cancers that indeed are not. We want to make sure we're making the correct diagnosis, and likewise looking at the CT scan you presented in terms of trying to decide whether one is going to do a surgical procedure, chemotherapy, radiation. I think that one has to get maximal information about the tumor and the extent, and we all know that CT scans are pretty miserable for being able to tell that. And this is a case clearly that I think MR is going to give you more information about the extent of sinus involvement and dural involvement. And also there's probably a role here in terms of the use of PET imaging, both for distant disease and to look for retropharyngeal nodes. So I think looking at the totality of what one is going to do, I think this is a case that really cries out to individualized treatment. And clearly, a lot of these tumors that are quite extensive, we would treat those at our institution with upfront chemotherapy and radiation therapy. It's very difficult, as many of our neurosurgical colleagues will state too, that once patients have had chemotherapy and radiation therapy, to go back and to try to do any type of craniofacial resection has a much greater incidence of morbidity and CSF leak as well. So I think adequately trying to define the extent of the tumor and plan the appropriate initial therapy is very important.
Very good comments.
I think we together have performed TPF plus radiochemotherapy in such cases, I think 8 or 9 cases in Frankfurt. And we have 1 or 2 complete remissions, but the relapse was after half a year we have relapse. So I think together with the highest possible chemotherapy protocol, TPF plus radiochemotherapy, we could solve the problem.
Thank you.
Amen.
Slides, please.
What did you do with this patient?
She's getting chemoradiotherapy. So this is a young woman that had a adenoid cystic carcinoma from the lacrimal gland. And Professor Rapides, how would you approach this one?
Well, this is obviously a case that the adenoid cystic carcinoma comes from the lacrimal gland.
Yes.
And it's certainly an intracranial extension because it's the roof of the orbit in that area, it's very thin. So we have to take in account the biological behavior of the adenoid cystic carcinoma, which by the time that is visible, it will have gone via the optic nerve microscopically inside the brain. So whatever we do, we are talking about a palliative treatment. Now, the good thing about the adenoid cystic carcinoma is that it has a very good 5-year survival and a very bad 10-year survival. So our approach to this patient would have been to operate transfacial and transcranial frontal approach. The use of postoperative radiotherapy in the adenoid cystic carcinoma is doubtful. It doesn't really give more than life expectancy, but I would use postoperative radiotherapy. And I will not use chemotherapy because it does not affect, there is no chemotherapeutic agent that is addressed specifically to the adenoid cystic carcinoma. So my choice would have been a cranial approach, wide local resection with orbital exenteration, of course. I would use probably the either a gallium flap to cover the dura or a latissimus dorsi if it is thin enough to cover the defect, and then proceed to postoperative radiotherapy.
Very good. Professor Boots?
Yeah, I would go for surgery as well because there are no studies which prove the effect of radiotherapy up to now in adenoid cystic carcinomas, and we know that they are difficult to treat, and the only treatment up to now is surgery. But as you pointed out, despite radical surgery, they might reoccur after a few years. But I think that's the only way, from my point of view, especially in this rather young patient to treat it sufficiently, and together with a neurosurgeon because of the endocranial extension. And then, of course, I think we need a reconstruction, and for this case, I think a latissimus dorsi flap would be just an ideal reconstructive procedure. And we have to discuss about postoperative radiotherapy. So it's always a discussion in large adenoid cystic carcinoma whether we should irradiate the patient postoperatively or just wait and scan and do some other procedures if the tumor reoccurs.
Professor Seifert, any special considerations for following the nerves proximally, addressing the cavernous sinus, not necessarily just in this case, but with adenoid cystics of the paranasal sinus?